The title of this video is the implant rehabilitation of the edentulous jaw using ProArch concept. Complete edentulism has been on the rise worldwide, and we need to address the implant-based rehabilitation of these patients using a proven, time-tested and non-invasive procedure like the ProArch concept. This concept provides an optimum fixed rehabilitation encompassing the removal of the hopeless teeth, immediate placement of 4 or 6 implants or more, bone level implants or tissue level implants for an interim immediate hybrid prosthesis. This surgery will take you through all the surgical and prosthetic steps right from treatment planning, the surgery, and later on as to how to convert the interim prosthesis into a provisional fixed chair-side prosthesis. The ProArch solution comprises of implants and screw-retain abutments and the prosthesis to serve the patient's functional and aesthetic goals and provide flexibility required in deficient bone of the jaw anatomy where conventional implants may not be possible. The patient was a 65-year-old male, non-smoker, non-diabetic with no relevant medical history. Patient had an existing upper and lower denture, and the lower denture would be used to serve as an interim fixed prosthesis during the osseointegration and the healing period of the implants. Radiographic evaluation for the lower jaw was done using a CBCT scan with cross-sectional analysis to evaluate the bone volume available for placement of 4 bone-level BLT implants, and a surgical stent was fabricated, duplicating the existing setup of the teeth in clear acrylic. The stent was fabricated with clear patency for drilling freedom and at the same time allowed the accuracy of the implant positions in relationship to the prosthetic setup, which leads to the reverse engineering protocol for the final prosthesis. The scan analysis indicated only sufficient bone height and width available in the interforamina region for placement of only 4 implants and not more. The anterior implants were placed straight and the distal implants were planned to be tilted by 30 degrees to bypass the mental foramina and reach out more posteriorly as per the required trajectory of the prosthetic setup. After local anesthesia, a mid-crestal incision was given and pilot indexing markings were done using the round burr from the surgical kit, using it as a template and as a guidance appliance tool. Now to fixate the planning template, a midpoint drilling in the mandible was done with the standard 2.2 drill pilot up to a length of 10 mm. The mid-symphysis mente is used for the accurate midline along with the help of the surgical template to determine the exact midline. The planning template is bent as per the arch form of the lower jaw as per the need and is moved on to the adjusting swivel and fixed so that the markings for the straight 0-degree implant placements and the tilted 30-degree implant angulations are predetermined. Depth and diameter drilling sequence are utilized as per the protocol of the implant system for placement depths up to 12 mm in the anterior region and 14 mm in the posterior region for the bone level implants. Sequence of the drilling to the desired depth with wider diameter drills is carried out until the final osteotomy size is ready. We may have to use the profile drills to create countersink effect for the drills in dense bone protocol conditions. It is optional, however, to use the screw tab. The planning template is adjustable with the swivel to mark the position of the implants and then tighten so that we have accuracy of the implant angulations for the 0 degree and the 30-degree angulations, and care is taken to accommodate that. The implant placements are done using the locksome driver attached to the handpiece to a torque value of 50 newtons per centimeter square, which is set on the physio dispenser or the implant motor and then adjusted to full depth using the manual wrench to obtain complete submergence of the implants on par with crestal bone as per the surgical protocol. The locksome drivers have an inbuilt safety feature to break off at 80 newtons per centimeter square, so care has to be taken to ensure that the implants are not over-torqued into the osteotomy, which may be damaging to the implants and the connection areas. Then it will become mandatory to use the profile drills and the screw tab in dense bone protocol to completely seat the implants in level with the crestal bone. We leave the locksome drivers in place on the implants for further evaluation of the parallelism of the anterior implants and the tinted implants before proceeding further with the surgery. The distal implants are placed at 30-degree angulations and also torqued manually to obtain complete submersion of the implants, and we take a confirmation with all the 4 locksomes in place. The distal implants, however, due to the tilt, will inadvertently have an excess bony lip and interference on the mesial side, which will need to be removed for complete seating of the angled SRA or the angled multi-unit abutments, as it is called in this particular system, onto the implants to completely nullify the tilted angulation. Therefore, guiding cylinders are placed on the distal implants and the bone profile drills are used in sequence to remove the bony interference or the overlap for the same to complete the passive seating of the SRA abutments. This is a very important step to do before final seating of the screw retained abutments, especially when there are multiple teeth removals and immediate implant placements have been planned and there may be lot of bony interferences. The screw retained abutments, which comprise 2 straight 0-degree anterior and 30-degree posterior implants angulations, are placed on all the 4 implants, and then the alignment pins connected to verify the final parallelism of all the 4 implants or the abutments connected to them to achieve a final goal of one common path of insertion and placement and eventually the retrieval of the prosthesis. This is the most crucial part of the surgery to verify the absolute parallelism of the alignment pins before proceeding any further. The tilted implant positions may have to be modified slightly to obtain complete parallelism using the type A or the type B SRA abutments before proceeding further for correcting the minor angulations of the alignment pins. The SRA abutments are finally torque fastened up to 35 newtons per centimeter square on all the 4 implants before connecting the healing caps temporarily before beginning with the prosthetic work. The flap margins are sutured back using the conventional single interrupted sutures around the plastic healing caps, and a light body silicone impression is taken to record the approximate positions of the same onto the denture impression surface. This ensures and guides the clinician to the accurate positions to drill into the denture acrylic to accommodate the titanium cylinders through the denture conversion protocol. The non-engaging titanium provisional cylinders are connected onto the SRA abutments, and the denture is tried on to make any final adjustments before beginning the chair side pickup of the cylinders onto the denture. However, the original surgical template is again repositioned on the connected titanium cylinders to re-verify the position of the access holes before proceeding further, just to ensure that we have proceeded with the original prosthetic plan as per the implant placements and have followed the reverse engineering protocol. The titanium cylinders are accordingly trimmed in height to match the occlusion and achieve the complete closure in centric relationship before proceeding with the actual chairside pickup technique. The chairside pickup technique utilizes any dual-cure resin available, which can be injected around the access holes and the corrugated surface of the titanium cylinders so that they get easily picked up and later on for the denture conversion technique. Please don't forget to block the access holes of the cylinders with Teflon tape or any material to prevent the resin from getting in between the SRA and the occlusal screws to prevent issues with prosthetic retrievability later. Care should be taken to not overshoot the abutment trajectory on the distal-most implants and deliver a provisional prosthesis which has an unnecessary cantilever distal to the most posterior implants during the healing period to avoid any complications of implant overloads and possible failures. The occlusal scheme of the provisional prosthesis should end almost the same area as per the distal access hole and should not extend anything beyond that. The advantage of using a dual-cure resin is because you can pick up the cylinders intraorally and then additionally light cure it outside the mouth for complete polymerization of the resin before any further modifications of the provisional prosthesis. The chairside pickup temporary cylinders are verified in the denture, and the denture is trimmed on the flanges completely to remove any ridge overlap, and the impression surface is later relined to obtain a hygienic convex profile to be refitted back onto the patient at the same time. Care should be taken to avoid any concave surfaces on the impression surface of the provisional prosthesis, which can lead to food accumulation and further infection and hygiene relation issues with the provisional prosthesis. The provisional prosthesis is torque fastened onto the occlusal screws up to 15 newtons per centimeter square onto the SRA abutments after complete evaluation of the occlusion and maximum intercuspation of the interim prosthesis before final delivery to the patient. The access holes of the immediate prosthesis is blocked with Teflon tape again or any suitable material to keep the patency access with the occlusal screws and then lightly covered with composite resin on top to preserve the accessibility for future and at the same time prevent any food trap and hygiene issues with the access holes. Kindly note that this interim prosthesis will be preserved untouched and unintervened for the next 3 months until the complete healing and the osseointegration of the implants, and then we will be proceeding with the final impressions for the digital CAD/CAM based titanium framework for the final prosthesis in the lower jaw. The interim prosthesis is finally verified in complete centric relationship and maximum intercuspation before the final delivery to the patient on the same day of the surgery. This patient will have a fully functional and aesthetic immediate provisional prosthesis as per the ITI protocols for the next few months until the fabrication of the final prosthesis. I thank you all for watching this video, and this is Dr. Anand Krishnamurthy signing off happily with his